Now we'll shift gears into lipid metabolism. The core components of a lipid panel include total cholesterol, HDL cholesterol, LDL cholesterol, triglycerides, and VLDL cholesterol. Now, these labs have historically been the foundation of cardiovascular risk assessment, but as we move through this section, you'll see how traditional lipid panels can miss the mark and why more advanced lipoprotein testing is gaining traction. Understanding the strengths and limitations of each parameter is key to managing dyslipidemia effectively. There are typical reference ranges placed here, and a fasting lipid panel is ideal about 12 hours to get an accurate triglyceride value. Total cholesterol around 150 to 200 is desirable. HDL above 50 is generally protective. LDL below 100 for most patients, though clinical targets vary with risk. Triglycerides should be under 100 for optimal metabolic health, but are considered normal under 150. Ratios such as total cholesterol to HDL and HDL to LDL are also used to evaluate risk, and these numbers kind of set the stage, but as we'll see, they don't always reflect what's happening at the lipoprotein level. When you order a lipid panel, not all values are directly measured. Total cholesterol, HDL, and triglycerides are measured, but LDL and VLDL are calculated. This is where the Friedewald equation comes in. VLDL equals triglycerides divided by 5, and LDL is calculated as total cholesterol minus HDL minus VLDL. This works reasonably well when triglycerides are under 400, but when triglycerides are high or in metabolic syndrome, direct LDL or the calculated LDL can be wildly inaccurate. Therefore, a direct LDL measurement or more advanced lipoprotein panels give a much better source of information when we see elevations in triglycerides. This is showing kind of the shift away from relying solely on LDL-C numbers towards assessing lipoprotein particle numbers and sizes. Research shows that lipoprotein particle count is a better predictor of cardiovascular events than cholesterol content alone. Consensus statements from the ADA and ACC acknowledge that traditional lipid panels miss a subset of high-risk patients, especially those with insulin resistance or mixed dyslipidemia. So while we still order the standard panel frequently, it's important to understand why it might not tell the full story. VLDL are very light or very low density lipoprotein, carries triglycerides from the liver to peripheral tissues and transforms into IDL and eventually LDL. VLDL has apolipoproteins B, E, and C embedded in its surface. When VLDL is elevated, such as in diabetes or in states of hepatic overproduction, it does reflect a metabolic imbalance, often tied to insulin resistance, fatty liver, and cardiometabolic disease. Because VLDL is calculated as TG divided by 5, an inaccurate triglyceride value will skew VLDL pretty significantly. LDL, low density lipoprotein, carries cholesterol esters from the liver and tissues throughout the body. Its structure includes a phospholipid monolayer and one ApoB100 molecule, which is important because ApoB reflects the number of atherogenic particles. Clinically, LDL targets vary depending on a patient's risk category, but less than 100 is often used as a benchmark. The problem is that calculated LDL becomes unreliable when triglycerides are high. For patients with metabolic syndrome, direct LDL testing or ApoB levels may be far more informative. Major causes of increased and decreased LDL are listed here. Increases are associated with primary hyperlipoproteinemia, high-fat diets, an acute heart attack, hypothyroidism, nephrotic syndrome, diabetes, and several medications. And decreases can occur with advanced liver disease, malnutrition, or rare conditions such as A beta lipoproteinemia. Knowing these can help you interpret an expected LDL result. For an example, a patient with newly diagnosed hypothyroidism may have LDL that looks like uncontrolled genetic dyslipidemia when it's actually endocrine driven. Triglycerides are an energy-dense lipid composed of three fatty acids attached to glycerol. They are produced from excess carbohydrates or absorbed from dietary fats, and then they're stored in adipose tissue. High triglycerides can reflect metabolic dysfunction, alcohol use, and endocrine disorders or medication effects. They're particularly important because the very high triglycerides above 500 significantly increase the risk of pancreatitis. But even moderate elevations contribute to cardiometabolic risk by promoting small, dense LDL formation. Cardiometabolic causes of elevated triglycerides include metabolic syndrome, diabetes, acute MI, and other causes include pregnancy, alcohol abuse, pancreatitis, nephrotic syndrome, and renal insufficiency, as well as hypothyroidism, Cushing's, and certain meds. Genetic disorders like familial hyperproteinemia can also be involved. Therefore, when evaluating hypertriglyceridemia, it's essential to conquer or to consider lifestyle, diet, alcohol intake, endocrine disease, medication lists, and family history. Low triglycerides, on the other hand, can occur in malnutrition states, A beta lipoproteinemia, and from medications like gemfibrozil, nicotinic acid, clofibrate, and omega-3 fatty acids. While less clinically dramatic than elevated triglycerides, very low levels can indicate malabsorption, chronic illness, or aggressive lipid lower therapy, and it's important to interpret low triglycerides within overall nutritional status. Cholesterol, triglycerides, and phospholipids are shown here. Total cholesterol reflects the sum of HDL, LDL, and VLDL. Normal is below 200, but total cholesterol by itself is not useful for risk stratification because it includes both protective HDL and atherogenic LDL particles. Still, it's helpful for broad screening and also for insurance-based metrics. Also, very high values could point towards familial hypercholesterolemia. There are the standard screening recommendations listed here. Men over 35 and women over 45 should be routinely screened. Younger adults, such as men between 20 and 35 and women between 20 and 45, should be screened earlier if they have risk factors like diabetes, hypertension, or a strong family history. Screening is important because early dyslipidemia often has no symptoms, yet contributes significantly to long-term cardiovascular risk. In clinical practice, we often screen even earlier in patients with obesity or metabolic syndrome. Lastly, apolipoprotein B or ApoB is found on all atherogenic particles, VLDL, IDL, LDL, and LPA. And elevations in ApoB, especially over 130, is considered a risk-enhancing factor for atherosclerotic cardiovascular disease. ApoB testing is particularly helpful when triglycerides are elevated or LDL is discordant with the clinical picture. Because ApoB reflects particle number, it's more of a direct measure of atherogenic potential than LDL concentration alone.